All right, I'm going to start.
Yes, please.
So we have
Thank you.
pretty advanced group here, and I put in some of the patho with aortic valve mostly, and I know you guys don't really need that, so we'll whiz through that a little bit. And y'all know me. So prevalence of aortic stenosis. This is actually an older slide. I need to go out and find a newer one, see if it's changed at all. But 77% of the population over 65 has severe aortic stenosis, and 80% of the symptomatic ones are males, which I do kind of see in my practice. So, age-related is the most common form of or cause for aortic stenosis, and high-dose radiation to chest is the least common. But rheumatic fever, I think, is going to eventually fall down that ladder a little bit there. Obviously, we don't have that as much, but our old aging population was exposed to that. And then congenital abnormalities. I wouldn't say that's on the rise necessarily, but it'll be a continuance, I would expect. So those are our bicuspids and unicuspid, although I've never seen that before, but I've heard about it. And these are just nice little pictures of the different types. So top left is, or number A is the normal aortic valve. B is, top right is the bicuspid. C is your rheumatological aortic damage, and then and you can see there obviously why it would cause insufficiency as well as stenosis. And then D is your typical age-related calcific aortic stenosis. So here's all the numbers that we tend to go by. You know, a lot of times, especially when I started, I focused on those numbers. I focus a lot less on those numbers and obviously more on the patient's symptoms, because there's so many things that can affect the calculation of the numbers, whether it be the patient's own hemodynamics, their EF, their size of their ventricle, or whether it be the operator who's doing the echo. So you really have to trust your assessment more than the numbers, in my opinion. And then we have the different pictures of the reasons why you can have you know, low or normal numbers, but the patient actually does have severe aortic stenosis. We have the normal left ventricular systolic function, normal flow, high gradient. So that first one that you see is going to have to meet that 4 meters of peak velocity. It's going to have to meet the 40 millimeter mercury. The middle one is your normal left ventricular systolic function, but they have a low flow, low gradient because, as you can see, do I have a thing here? Their cavity of their ventricle is very small, so their stroke volume index, if is less than 35, then that's going to indicate, even if they have a normal EF, that you do dopamine stress on them, because they are not going to be able to generate the velocities needed because they just don't have as much flow. Another thing you have to look at too is their mitral valve. If they have a lot of mitral regurg and half of their flow is going into the mitral valve and not out the aortic, they may not be able to generate those velocities either. We actually did a patient yesterday with, she actually had mitral stenosis, but a combination of MS and MR plus aortic stenosis. We did a double valve on her. It was really cool. And she's doing awesome today. So, so that is probably the unicorn a lot of people don't catch, you know, because your gradients are not that high, your EF is normal, so you would think, oh, they're just not bad yet, you know. And then you have the classic low flow, low gradient, which is your EF is, you know, less than 50%, and they have dilated left ventricle, and they just don't have the power to produce the gradients necessary, even though their aortic valve is very calcific and not opening well.
So what do we need to look for on the echocardiogram to indicate that we...
On the echo?
Yeah.
So look at, if you say, let's say they don't meet, but you think, wow, they really seem like it and they sound like they have severe aortic stenosis. Mm-hmm. If you can actually look at the images, look at that valve and see if it's calcified. It's going to be white, and you can see if it's opening or not. Hopefully you can get an accurate area, but that's something that's very subjective from one echo tech to another. So don't weigh entirely on the area. but see if that's low. Look at the dimensionless index. If it's less than, really truly less than 3.3, then you know it's severe, regardless of what anything else says. So
I'm not sure what the dimensionless index is.
The dimensionless-
I see that they've started adding
right.
that in description, but I'm not sure where that falls.
So I have a hard time explaining
That's
that.
okay if you that's fine.
And I don't have a calculation on me how they calculate it, but it has to do with their body surface index
Okay.
and their flow through the
So
valve.
it's something to
the
do with
measurements.
stroke
Yeah, it's a
volume.
calculation that they do on their computer.
Okay.
Um,
So less than 3.3?
less than 0.3.
Less than.
Less than 0.3. So you'll see 0.5 is pretty good, 0.4, you're getting there. If it's 0.3 or less, you know that they're in the narrow to severe range.
Where do I find that on the echo report?
It's usually lower
Okay.
if they do it. And Corey, I apologize, in Effingham, they don't generally add that there. Sometimes you don't even get the stroke volume index. So if you're not getting those two numbers and you're worried about it, you need to ask your echo department to calculate that out for you.
Remind me what the stroke volume index concern number would be.
Huh?
The stroke volume index, where are you concerned for severe?
So less than 35.
Less than 35.
Yep, 35 milliliters basically there.
Less than 35,
So.
less than 0.3.
So,
I'm gonna add that.
and then the area, obviously it's less than 1 centimeter.
Can you send us all these measurements in an email?
Yeah,
That would
yeah,
be
darn
extremely
it.
helpful.
Gosh, I wish I'd have put a whole slide of that in here. That would have been awesome.
Because
I thought they used
I
6.8.
do sometimes go to echo.com. They give
Mhm.
all those measurements, but it would be nice to have it
Yeah.
more concise.
I
I'll
wonder
send out
if
like
it's
a
in
copy of an echo and then
Let me see
highlight.
if it's in the ACC app.
Okay. All right. So symptoms,
that's all there.
you guys all know about the symptoms of aortic stenosis. Shortness of breath with exertion. I find that the very early symptom is just overabundance of fatigue. I fall asleep all the time. You know, every time I sit in a chair, I fall asleep. And most every older person just attributes that to I'm old. You know, so shortness of breath with exertion. Sometimes you have to really fish that out of them because maybe they're just limiting their activity in order to not get short of breath. So they say, well, no, not really that short of breath, but well, how far are you walking? Well, you know, and then orthopnea, that I feel is more of a later sign. Angina is more of a later sign. I have so many patients that describe this heaviness or this pressure on the left side of their chest. They feel like it's going to explode. It just, you know, and it as soon as they wake up from the procedure, whether it be surgery or TAB or whatever, it's gone. And so that's kind of cool that I see those symptoms people didn't even know they had, and they're gone afterwards. So, feeling faint, weak, or dizzy when they stand up. A syncopal episode related to aortic stenosis is a very late sign, and it's a bad sign. And in my experience, they're not going to make it much longer once they have the syncopal episode. So, and then obviously heart failure can come along in any stage of aortic stenosis because there's always other factors such as the diastolic dysfunction and, you know, of course, EF, and that all plays into that. So, and if it gets real bad and they start to develop, you know, high pressures in the left atrium and then in the lungs and then start to develop right heart failure, then that's when you get the right heart symptoms and the peripheral edema, abdominal ascites and everything. All right, so these were the standard approaches. Transaortic and transapical are rarely done these days. Used to be done a lot because the delivery systems were so large. So when they first started doing this here, we were talking like 24 to 26 French sheaths in order to insert these transfemorally. So as you can imagine, not a lot of patients that were high to prohibitive risk for surgery had access to do that. So now the sheaths are down to about 14 to 16 French sheaths in the groin, and that's pretty doable for almost anybody. Their diameter of their vessel only has to be about 5.5 millimeters. These numbers of how long you think they'll be in the hospital, if you think they'll survive, what the percentage of renal failure, infection, reoperation, all that. So pulmonary function testing, we do rely pretty heavily on this as well. People that have poor pulmonary function, particularly related to chronic lung disease, are they really going to benefit from an aortic valve replacement? it's such a toss up, and this is probably the thing we talk about the most in our meetings is that, oh my gosh, like I just had a lady in her 60s and her pulmonary function was horrible. She was on chronic oxygen, but she would die a lot quicker because she would have the heart failure on top of the chronic lung disease. And, you know, it's a high predictor of poor outcome in these TAVR patients, but just because she had been such a functional person, we decided to go ahead and do her. And she's doing amazing. And her pulmonary function doubled after the procedure. So it makes you sit back and look at it like, oh my gosh.
I think those
You know?
pulmonary function tests are so subjective too.
They
Does the
are.
patient feel crappy that day?
Exactly.
They having a good
What's
day
their
or a
effort?
bad day, you know?
Yeah. We did have her see a pulmonologist, have her have multiple testing. You know, they did their own testing there, and she still did poorly. But her IS before the procedure, she only could get up 400. By less than a month, maybe like the 2-week visit after the procedure, she was 1,200. She could inspire. So she felt a million. She called herself the Energizer Bunny after the procedure. It's great. Again, why these are important, we kind of talked about that. I think I'm going too slow here. Risk profile. So the frailty, we do an ADL evaluation. It's just like a check off. You know, can you take a bath? Can you shower? Can you, you know, and then whatever their number comes out is what we do. No frailty or yes. Grip. That depends on their sex and their age. You know, as to what their grip is, and we've got a chart for that. And then the 5-minute or the 5-meter gait speed. We used to have to do a 6-minute walk. We don't have to do that anymore, only for the mitral clips. So the 5-meter gait speed needs to be less than 6 seconds. And then albumin within the normal range or low. And so depending on how many levels of frailty, also, if they have 1, they're also automatically intermediate risk for surgery. So. All right, so old picture, but this is the team meeting. Now we do it every Wednesday. We used to do Tuesday, Thursday, but now we just do TAVRs once a week, so every Wednesday. So I feel like we get a better attendance at the meetings, which is really nice. So at the meetings, all the docs, it's a really fun meeting. You guys are all welcome to come. If you ever just want to come and see what we're doing, the amount of discussion that goes into each case is really cool. It's fun to be a part of that. You know, and they listen to all of our nurses in the office who deal with these patients, you know, on the phone and in person. They listen to me if I have any suggestions, you know, if I've seen them, and they talk it out between each other. It's pretty cool. The surgeons are a huge part of that because there's always seems to be a question of, oh, well, this patient, you know, has this. Would they do better with surgery or would they do, you know, worse? And so we rely heavily on the surgeon's input during that meeting. We decide, once we make the decision we're going to move forward with the case, they decide the approach, whether it be surgical or transfemoral, which type of valve we're going to use, and then most of the patients these days, actually, we're trying to do with conscious sedation. It's really cool. They were like literally talking to us during the procedure. But otherwise, we use general or MAC, depending on their comorbidities. If they have sleep apnea or if they have any kind of dementia, we'll use general because they can't lie still and they have to. They cannot move when we're deploying the valve. So the day before, we bring them in for PATs or we admit them. And we'll do all these labs and meet with the anesthesiologist if they're having MAC or general. And then they'll see the cardiologist performing the procedure. It may not, you know, if a patient requests a specific cardiologist, we definitely honor that request. But if they need to get on as soon as they need to get on, they might be seeing a new doctor, you know, that's never even never seen them before is going to do the procedure, so they'll meet with them the day before. If they have any renal insufficiency, we'll admit them and we'll hydrate them overnight before the procedure, review their meds, and we'll talk to them about which meds to hold and treat any abnormals like potassium if it's off or if they have a UTI. So this is kind of a mini medication management. It's one of my goals this year is I'm going to do a whole medication management, you know, for TAVR, but it could be used for hopefully any, and I know it's been done before, so I'm going to look for what's been done, but I did this in my last job. But we hold the Coumadin. Most of the time we just hold the Coumadin, sometimes we'll bridge. They will do the procedure if it's less than 1.6, maybe even a little higher, depending on the doctor. We have them take aspirin throughout the whole procedural. We have them take Plavix throughout the whole peri-procedural experience. If they're not on Plavix, if they're new to Plavix, we'll load them with 300 milligrams afterwards. If they're on a NOAC, we do start that 48 hours after, and then I'll resume it the next day. Big question about NOACs. I'm not supposed to take a NOAC if I have an artificial valve. If you're taking the NOAC for AFib, and you're not taking the NOAC for a valvular, you don't have a mechanical valve, you're not taking it for anticoagulation for the valve in particular, you can continue taking it. Now that is our stance on it. ACC guidelines don't have that stance yet, but they're getting there. So, but that's how our doctors prefer it.
Okay, let's go back.
Okay.
So if I have a patient who is on Eliquis prior to the TAVR, they can be on Eliquis after the TAVR.
Because they're taking it for AFib.
Right.
Now, if it's a mitral valve, it might be a little different. But if we're doing the aortic valve, they can definitely continue the Eliquis.
Because standard of care for your TAVR aortic valve prosthesis
It's
is
just
just aspirin and
Plavix
Plavix,
Yeah,
right?
just
So
Plavix
you're
and aspirin.
already
So
integrated.
we're not
You're
using
doing
that
Plavix
Eliquis.
30 days, is that right? Or how long?
I've got that on here.
Okay, sorry.
Or Brilinta, like we had one patient recently. If they're on Brilinta, then we keep them on Brilinta. We don't switch them to Plavix.
Gotcha. So if they're on Brilinta for like a stent or
Exactly. Yeah. Or if they can't tolerate the Plavix for some reason, then we do Brilinta. Metformin, like you would do for a regular cath, 48 hours after. I don't even give it at all in the hospital. I just have them started once they go home. ACEs and ARBs, that's another one that should be held. There's talk that it maybe should be held for 72 hours before a procedure that you have contrast. And then depending upon the renal function, I'll start it a couple days after. Sometimes if they're hypotensive, I'll wait till a week or so afterwards to restart the ACEs and ARBs. But we definitely do want them on it because it shows a longer, better mortality, and it shows better function of the valves. People that take them live longer. So beta blockers, that's one that we've kind of gone back and forth on. You don't want to just stop somebody's beta blocker, but on a TAVR procedure, you also don't want them coming in at a heart rate of 40. And then you block them even more, potentially. So depending on the patient, if they come in and their PAT and their heart rate's already 90 or 100, we'll have them take like half their dose the next day of their beta blocker. If they come in and their heart rate's 50 or 60, we'll just have them hold it. And then I might not even resume it out, like at a full dose. I'll just give them a half dose that evening and then resume as needed. But it's something that is patient specific for sure. Calcium channel blockers, we generally just hold those. Diuretics, always hold those day of procedure, and because most of these patients tend to need to be more wet, we don't want them dry at all during the procedure. And then respiratory medications, basically most of their other medications, particularly definitely give them the prednisone. We sometimes will give them a bolster dose of steroid if they've been on chronic prednisone. And, and the Lantus, that's one that we're so used to holding half when they used to take 70-30 all the time. But my understanding of Lantus now, if they have a basal rate, we don't need to half that, but that's how we're doing, it right now. And then we go to sliding scale in the hospital with Lantus, but I'm going to try to change that, thinking that's going to be my medication management project. So we'll work on that. Day of procedure, so they come to the procedure, they have their TAVR, usually takes an hour to an hour and a half. A new thing that we're doing, did you guys hear about the Sentinel devices that we're using for the prevention of strokes in these patients? So we put it in the right radial artery, goes through the brachial, and into the right innominate, the common carotid on the right side. We put like a filter that looks like a cone shape, and we set that there, and then we run a filter up to the left carotid artery. Put a filter there that's a cone shape. It just stays in there during the procedure. We remove it afterwards. They've gotten really good at this, and it takes them about 2 minutes to put it in. It's pretty awesome. And so far, the data is kind of soft on it. We don't actually get reimbursed for it yet. It's approved for FDA use. But we're just looking to see if this is going to help. So far we've had one patient that's had a stroke since we've been using it, but we think that stroke occurred actually the day after the procedure, not during. So it's
Was that a big problem before this?
no, that's the thing that most sites are saying. They don't want to add the cost of this procedure because the stroke rate, our stroke rate was about 2%, which is pretty low, but
Unless you're that 2%.
Right.
you don't
unless
want to be that 2%. Yeah, if we can make it 0, then we would love to do that. So,
It's still the case. I think when you first started doing it, though, the stroke rate varied greatly based on how many a center was doing. So the more
experience the
the more
center
experienced
is
surgeons
right.
had less, or providers had less stroke rate, because that was the
Right.
biggest prohibitive thing, I think, in the early time was the stroke.
And didn't they show too? You have to check MRI because there are a lot of silent strokes that happen
Right.
in these kinds of procedures.
that's
that
what
don't
the
cause any
Sentinel's trying to
disability.
say. They're trying to say
Right.
that they're preventing these, strokes that, like patients
that we don't
have,
even know about.
Yeah.
That maybe they have a little
subclinical,
vertigo later. Or they
right?
have a
Or
little
they
vertigo.
have headaches, or they have, So we'll see. I don't know, but we're using it because it's safe and it's we feel like doing something is good,
Yeah.
So we'll see if that's the right thing to do eventually, as medicine tends to put us through. So the day of the procedure, depending on where they recover, if they have general, they all go to crew. If they're sick, they're hypotensive or hypertensive, they all go to crew. But most of them recover in post-cath, and then they go out to CVCU. If they have any kind of heart block or left bundle branch block, we may keep the temporary pacemaker in for a few hours afterwards. I usually remove that before I leave for the day. But occasionally we'll have to leave it in overnight. Most of the time, I would say now they're taking them out at the end of the case. The hemodynamic changes, and we kind of talk about this in a little bit, can depend on whether they are hypertensive, hypotensive, and I find that now that we're using more conscious sedation, I have a lot less hypertensive patients, which is awesome, But they can get either, it's like opening the dam. You go from really tight valve to just a wide open valve, or so you can get really hypertensive, or they can have this total vasodilation effect, and then they can be hypotensive. Obviously, the people with low EF tend to get hypotensive afterwards. Evaluate for stroke. That's the first thing I do when they get back into the post-cath, is make sure that everything's working right. Monitor groin sites, same as you would do for any femoral procedure. And then the labs and EKG and chest x-ray post-procedure. These are the actual procedures. I don't think we have time to go over those. But you can pull it up on YouTube, and there's pretty cool cartoon procedures. I like this slide because the pressure tracings, we don't always do these with every patient, but what they'll do is, so this one here is in the left ventricle, okay? So see how high the pressure is in the left ventricle? And then this is in the aorta. So the difference in the pressure is your gradient. So this person's gradient is 112, sorry. That's high, that's really high. After the procedure, this is what it looks like. They're equal. So that's how they're going to feel better afterwards. It's really cool to see that. This is the keep or remove temporary pacemaker. Lady yesterday went into asystole twice, although she came out of it, and I was able to take her temp pacer afterwards. I was sure we were going to have to put a pacer, and I even called Dr. Issa. Yeah, the double valve. I even called Dr. Issa. I'm like, I think you need to come and look at her, like during the case, just because I didn't want it. She was general, and I thought if we're going to put a pacer in, we'll do it now. But she pulled out of it. It's pretty amazing. Post-TAVR complications. The perivalvular regurgitation is not as common as it was when they first started because they've made improvements on the valves. CVA 2.5, like I said, the last calculation before we started using this Sentinel was more about 2%. Rhythm disturbance, 10%. Ours is actually down around 8%. And I think it's getting even better and better. I don't know if it's because of the evolution of the valves or just our doctors are getting better where to land them. The lower you land them, the higher the risk for heart block. So they land them a little higher than they used to. And it's working well. Pulmonary issues, mainly with general patients. And then obviously, especially with the general patients, we have them use the IS. It's just as important in TAVR. not quite as important as it is in SAVR, but I make sure that they're using that. Fluid balance, like I said, usually I want them a little on the wetter side, especially that first day to prevent suicide ventricle, which I'll show you a picture of later. Infection, mainly if that's a surgical, but you always watch the groins if they've got large pannus and they can get fungal infections in there. It's really just a small poke hole, but I still, there's a potential. I've seen one get infected. Debilitation, if they were very debilitated before the procedure, usually is dictates how they're. A lot of people are barely just limping along at home, then the family brings them to the hospital and they're like, here you go. Mm-hmm. And then I have to put them in rehab afterwards, even though it's nothing related to the case. It was just so. Tamponade, if there's a myocardial perforation, a lot of times that occurs from the pacer lead in the RV. Whenever we put a temporary pacer in, that happens. They'll and I find that it's more with patients that are on chronic steroid use. They have poor tissue, so Dr. Goswami actually just came up with a new way to pace somebody with a safer, even safer than the pacer that we're using now. But that's interesting. It's going to get written up. So, an acute kidney injury, obviously the contrast nephropathy. It's kind of nice. It's a double benefit in that I give patients fluids after the procedure to help keep them on the heavier side or the thicker side, as far as their fluid balance goes. But it helps the kidneys too. If they have a lot of hypotension during the kidney, during the procedure, they can get pre-renal. And we usually see that about 48 hours after the procedure is the peak of that. So complications, again, the ventricular rupture for pacer. Acute valve dysfunction, I've not seen that, but I can imagine that would happen. The coronary artery obstruction from the native leaflets, like we talked about. I've seen that a couple of times. Sometimes if we're suspecting it, we'll even park a wire in that coronary artery and a stent. We'll deploy a stent hanging out just a little bit to keep that leaflet pushed off the opening so there's still flow. And then if patients have an EF of 25% and we have to do a rapid pacing on them, I've seen them just totally crump after that. And we have to do Impella and, give them a day or so. It definitely can get cardiogenic shock from that. So the suicide ventricle is, if a patient has left ventricular hypertrophy, particularly the septal hypertrophy, you can see right below the aortic valve here. This is the LVOT, the left ventricular outlet. And so they're really, really large here. And then all of a sudden, they're used to having this high pressure from the valve, so it creates this constant tension, and then all of a sudden the tension is gone, and then their ventricle will kind of clap down on itself like this. And so normally they'll do that, and they should be able to, compensate for that, but if they have a really thick septum and it completely clamps down, it obstructs that LVOT completely, and then those people get profoundly hypotensive, and you're trying to figure out why. Well, it's because they don't have that tension, so that's why we have to overhydrate them and increase their preload in order to keep that ventricle distended a little bit until their body just adjusts to it. So that's like the first 4 hours or so after the procedure. That's what I'm battling. Stroke, we hope we never see it. Hate stroke. Heart failure. So I'm going to probably overhydrate them maybe the day of the procedure, and then the next couple days I may have to catch up. So periprocedural MI, we talked about that. There could be either a embolization of like a calcification go into one of the coronary arteries, or rarely even a blood clot. If there was one on, if there was like a thrombus on the valve, that could embolize into the coronary arteries. I've seen that one time. Usually it's a calcification. But that's less than 1% the chance of a periprocedural MI. Infection, we all know about that. Antibiotic prophylaxis recommended lifetime for all these patients. Post-procedural labs. I typically see a 2-gram drop in the hemoglobin. Whether or not there was much blood loss, I think there's a lot of beating up of the blood cells during the procedure from the balloon dilations and the platelets also generally drop 30 to 50 K, but they usually are popping back up within 2 to 3 days afterwards. So a lot of times I'll recheck these patients in about a week or so after. And then the BMP and MAG, of course. Post-procedure testing, kind of talked about that. I look at the chest x-rays just to make sure the valve's where we put it. Haven't seen one move yet, but that could happen. And we always do an echo the next day to recheck the valve. A lot of that has to do with our registry. We have to have a specific information for the registry in order to stay compliant, and they don't always get that in the post-procedural echo. So it's also nice to be able to make sure there's not an effusion the next day and makes everybody feel better. So anticoagulation. So typical patient that has no coronary artery disease and is on an aspirin a day already. They basically take aspirin and Plavix just for 3 months. If they develop or they have atrial fibrillation prior to, they can take aspirin or aspirin plus Coumadin. They don't need to take Plavix. Or if they're already on a NOAC, then we'll resume the NOAC. If the patient has AFib and they've had a recent coronary stent, I've had a couple patients that have triple therapy. So the aspirin, Plavix, and Coumadin. And of course, like I said, they can do Brilinta instead of the Plavix if needed. There's been a lot of studies, particularly over in Europe, studying patients just giving them aspirin and no Plavix, and they're looking good. So this is something that's variable. It's not in the guidelines. I think most centers do it this way, but they don't have to, So this is just the way. When I first started, we were doing Plavix for 6 months. Then the docs backed it off to 3 months. So, and the purpose of that is they think that the frame is endothelialized by 3 months. So then they don't need the Plavix anymore. EKG changes. So if your patient comes in to the procedure with a pre-existing right bundle branch block, because we generally bump off the left bundle because that's right next to the aortic valve, we can put them into a complete heart block a lot more often. So they have a higher incidence of pacemakers, and we'll tell them that before the procedure. And then the left bundle, they may develop right afterwards, but it could resolve over the first 24 hours, or it could stay. So if somebody has a left bundle and you feel like their cardiac output is not what it should be, or you think they're symptomatic from it, then you can send them to EP. And I think sometimes they'll put a pacemaker in them, just to help with that dysynchrony from the left bundle. But a lot of people just do fine with it. AV block, first degree, doesn't change that at all with this procedure. Second and third could progress. So those are the patients we watch. Those are the patients I think that end up 2 weeks after the procedure coming back for a pacemaker. And then AFib, we don't see that very often with the TAVRs, but I have seen it a couple times. Usually it's paroxysmal, meaning I've seen a couple where they just have it for a few hours after the procedure and then they convert to sinus, and then we'll put them on. We'll monitor them for a month, and then they won't have any more episodes. So this is just the etiology behind the left bundle branch block, because the left bundle runs right along here. So you can see why if we go a little too low with our valve, that we could end up irritating the left bundle. They describe it as like a bruise of the bundle, and that's why it'll recover once the inflammation's decreased, like a crush injury. So going home, I usually take the dressings off the following day after the TAVR, and then as far as their restrictions go, I tell them it's all related to the femoral sites. So you monitor them for bleeding and infection, and I tell them, knock on wood, I haven't had anybody have a bleeding episode outside of the hospital from one of the groin sites, but I want them to know what to do if it does happen. Just have them lay down and have somebody hold some pressure on it. And call 911 if it's bad, obviously. We don't let them get in a tub for just a transfemoral for 3 weeks or swimming. It'll be longer for your surgicals. Do you guys do 4 or 6 weeks for that? Like a hot tub or pool?
We do until their sides are healed, so usually 6 weeks.
6 weeks.
Mm-hmm.
Okay. We don't recommend any kind of creams or salves or powders or anything like that on the wound, just clean and dry. And then as far as lifting, I say no more than a gallon of milk for a week. And then have them walk 4 times a day like we would have them in the hospital until I see them at their 1 to 2 week follow-up. And then if everything looks good at that point, I start them in cardiac rehab. And then if they're safe to drive, some people aren't safe to drive before the procedure, so if they're safe to drive, then we let them after about a week or 2.
That's
So we see them now at the 1 week after procedure, 30 days after procedure, and 1 year. And then they follow up with their primary cardiologist, you guys, for the rest of it. And then obviously we see them again if need be. So this is a quick overview on MitraClip. I can't remember what the name of that doctor was that did this procedure, invented this. This is the mitral repair that the MitraClip was fashioned after. So it's basically trying to mimic that. Most patients have mitral regurgitation at the center of their mitral valve, which is at the A2, P2. And this clip is invented to try to mimic that by just clipping those 2 leaflets together, and that's decreasing the regurg. Works really well. I know a lot of you probably went to Dr. Goel's talk, so this is a lot of the same stuff that he talked about, but this is the indications for it, and it's the same. I'm waiting for the time when this is going to change, when it's no longer for only the prohibitive for mitral valve surgery, because this doesn't eliminate somebody as getting mitral valve surgery. If they get a clip and then it doesn't work, or they need to have surgery on their mitral valve in the future, they can still have surgery. So I think in the future they should consider it for intermediate risk patients. Right now the MR has to be more than 3+. It's usually more than 4+. Usually it's torrential MR before we do it. And has to be, says a primary abnormality, which means like a degenerative or myxomatous mitral valve. We do some functional though. If it's a combination of myxomatous and a functional mitral valve, we can still do a MitraClip on them. And it also has to be worked up in a heart team approach. As you can see, I think the mitral is going to explode a lot more, because mitral valve disease is almost 50% more prevalent than aortic valve disease. And this is significant mitral valve disease. So we tend to not treat it as often, because people can compensate for it by dilating their left atrium. And, but by the time you do get to them, then they're so sick. You get low EFs and huge left atrium. They're in AFib, and maybe in the future we could prevent it from getting that bad. So most of the time, your leaks are going to be right around in this area, the A2, P2. So A1, P1, that's near the aortic valve, and the A3, P3, that's near the lateral outside of the valve. So things that stop us from doing the mitral clips is if we have a thickened or calcified or short posterior leaflet that we don't think we're going to be able to grasp, or if these leaflets are so far apart, from functional, like a dilated ventricle, they're so far apart that we can't even grasp them that way too. But we can tell by looking at the TEE. This is the pictures you'll see after the clip. See how high the pressure is in the left atrium due to the regurgitation, and then afterwards it's awesome. We had that yesterday. I have it on my phone. Dr. Goel gets so excited about this stuff. Look at the change. Look at the change. Mm-hmm. So the workup for them is they obviously need a TTE, but as we said before, you tend to underestimate the mitral regurgitation on a TTE. So if you suspect it or if you hear it, always do a TEE with 3D, and then send them over and let us take a look at them. To evaluate the valve for appropriateness for mitral clip, we do send it off to the company, and they help us make the decision. But Dr. Zuck pretty much, he could run that. He's just amazing. He can tell if it's something that we're going to be able to help them with. So we do turn down a lot of people A lot of people are not candidates for mitral clip. Maybe they're a little too tight to start with, so if we put a clip in, we're going to give them mitral stenosis, or maybe they're too dilated. So they also get the surgical consult, but they only need one for that. But they have to be determined very high to prohibitive risk for surgery. They do frailty evaluation, PFTs, dental, just like the TAVR. And in this case, we don't have to do a cath unless they have symptoms. You know, so I find that interesting. But it's not as much of a stress on the heart to do a mitral clip. You know,
So
we don't have to pace them or anything. So.
I have a lady down in Rushville who's literally been sitting on my board because I don't know what to do with her for probably 2 months.
Mm-hmm.
If I want her to be evaluated by the structural heart clinic, can I just send you the information and you look over her paperwork before she actually comes here? Because
Oh yeah.
it's a huge thing for her to come
Yeah,
here.
or if it's huge for her to come here, you know, Goel and Goswami both go to Rushville. And they'd probably see her. You know, Goel would probably be happy to look at her over there. Especially the mitrals. You know, we like everything to come through Valve Clinic, but Goel is really our point guy on the mitral stuff.
Mm-hmm.
And so he will see a lot of mitral stuff outside of structural clinic too. But because Goldstein and Goswami and Goel are the three that do the mitral clips. So any of those could see him. But everybody discusses them, even if they don't do the procedure. They're still, and you know, obviously the surgeons will discuss them too. So the actual procedure takes. It used to be 2 to 3 hours for every clip because you're working with a moving target all the time, and they've gotten really good at positioning. And then we have a 4D, so we have 3D continuous during the case that Dr. Zuck is doing. You guys should come in and look at it sometime. It's like looking at, it's like you're inside the heart looking at it. It's so clear. It's so cool. So they've gotten really good at doing them now. I mean, our fastest one was like 45 minutes. And these guys have even less discomfort after the procedure than the TAVRs because they have one site. It's venous. Rarely ever get a hematoma or bleed. And they go home the next day. I've got 2 I'm going to probably send home today. And they feel better immediately. They're just like, wow, I feel... And so it's probably more, you know, makes me happy every time I see those patients. Typical stuff. So as far as the medication and stuff goes, aspirin, Plavix we do for 1 month for those. If not on Plavix, we will load them for 300 milligrams, but like I said, just 1 month because it's such a small little bitty clip, it'll endothelialize within a month. If they're on a NOAC, we stop 48 hours prior to the procedure. Sometimes if we see a lot of smoke in the left atrium, we will switch them to Coumadin. Most of the time, we leave them on the NOAC, and that's just the decision, you know, of our docs. And then Brilinta, they can stay on that if they're already on that. So no need to hold them at Foreman because we use 0 contrast during these procedures. Although we just don't have them take their diabetic medications the morning of the procedure anyway, but it's not like they have to hold it before. ACEs and ARBs, we do hold just because they're having general anesthesia, and then they'll get that hypotension related to anesthesia that people with ACEs and ARBs get. Beta blockers, we continue because we like the heartbeat to be slower while we're working. It's a lot easier to catch those leaflets. Calcium blockers, we continue that. Diuretics, we always hold just for the hypotension, and then all the other medications are the same as the TAVR. So, not a lot of EKG problems with this. We do not see blocks with the mitral clips. You know, maybe atrial fib, but that's usually just patients that were already in atrial fib before. And they have paroxysmal. They might go into it after a procedure like that. You guys understand the way we go through the atrial septum and everything for the procedure. Sometimes we do have to put PFO closure device in there. Most of the time we do not. As long as they can have like a little bit of a leak, but as long as it's a left to right and not a right to left leak, then that's acceptable. If this patient has terrible tricuspid regurgitation and high right heart pressures, they might have more of a right to left leak. And those are the patients that we're gonna close. We also have tried putting clips on the tricuspid valve and have been successful twice doing that. We can't do that as a standalone procedure. We can only do it in conjunction with the mitral clip because it's not approved, and we have to we have to use basically the leftover clips from the mitral. We're allowed 3 clips for the mitral, so if we use 2 in the mitral, we can use that last one for the tricuspid. See if it helps.
And does it?
Well, the one lady we did, she's like 92, and she's doing awesome. So I don't know yet. We don't have enough experience with it, but there's a whole study, that's doing it, and they're seeing it, improvement. The problem is most of the time, tricuspid is functional,
That's right.
and so it's rare that we're ever going to get
Right.
a tricuspid that works. This lady hadn't gotten sick enough to get, bad. She just had the really high pulmonary pressures and then bad TR. But I wonder if by fixing the pressures from the left side of the heart, if maybe her tricuspid would have gotten better anyway.
On its own, but while you're
Yeah.
in there, and if there's
Yeah.
no
So anticoagulation, the dual antiplatelet therapy, like I said, Plavix for 1 month, aspirin for life, and then the AFib. And then because it's the mitral valve, we tend to use Coumadin more than NOACs if they have or develop AFib. Or we put a Watchman in, which that's another study that's being done, doing the Watchman at the same time as the MitraClip because
I was
it's the
just
same
gonna ask you about
approach.
that. Yeah.
Yeah.
While you're in there,
Yeah.
most of those patients have AFib anyway.
Exactly.
And they're high risk. For
Yeah. Right now, you can't get paid for it,
Gotcha.
doing them both. But eventually, I think that'll be something. Hopefully, Medicare will see as a benefit, so you're not putting the patient under anesthesia twice. It'll literally take you an extra 15 minutes
Right.
and save the patient. So,
You can SD prophylaxis with the mitral clip.
yes, and with the Watchman. So right now, the Watchman, they're saying SBE prophylaxis for about 6 months, but again, there's not a guideline for that. So,
But for the clip, it is for the life of the patient.
for the what?
The mitral clip is a lifelong SBE prophylaxis,
Yes,
not short.
exactly. I think they probably could switch that since it gets endothelialized quickly. But right now, it's lifelong. So the left atrial appendage, everybody familiar with the Watchman? I can probably zip through here. These are nice pictures of the different appendages. They do have to have a TEE to determine their ability to have the Watchman and also measure which size we're going to need. And they can't have a thrombus in the left atrial appendage, and that's what this is right here. During the procedure, they can't have one there when we do it, unfortunately. So we like them to be anticoagulated before the procedure, but we understand there's some patients that are just not good candidates for it regardless. So we just like to get the TEE as close to the procedure as possible to make sure that they don't have it. We all know why we want to do it. The newest study that came out about the Watchman is not only is it as equivalent to Coumadin for prevention of stroke, but it's superior in that you don't have those other hospitalizations and side effects of being on an anticoagulant. So patients that have Watchman live longer than people that are on Coumadin alone. Now they haven't tested it against a NOAC because that wasn't their study procedure. So that's the big argument out there: is are the NOACs just as safe as this, and would it be better just to do NOACs? So, obviously, you have to have a Has-Blood score of 3 and a CHADS-VAS score of 3 as well, in order to be considered for anticoagulation to begin with, right? So basically, anybody who you would find at a risk, Has-Blood would be for the CHADS-VAS, anybody you would find to be a risk for a stroke, who you would start on an anticoagulant, is a candidate for the Watchman. The Has-Blood is 3 or more. That means they're a high risk for bleeding. So that's where the Watchman comes into play. Another thing you have to think about is you have the discontinuation rate, meaning patients who stop taking their medication, or maybe patients who are not compliant with their medication. When you think about those NOACs, the non-compliance is actually a lot higher than Coumadin because they just miss 1 dose and they're anticoagulated for 12 hours, or a day if it's a Xarelto or something. So the Coumadin, at least, if they miss a day, there's some delay effect, and so they still are anticoagulated. So you have to think about that. And those patients, if they're not compliant or not able to take it properly, they are also candidates for Watchman. These are reasons why we all know, why it's difficult to take care of patients. Some patients do great with anticoagulants, and they're no problem. You just leave them alone. But the patients that are difficult, this is a good procedure for them. It's very similar to the mitral clip in that there's very minimal pain associated with it, and they generally go home the next day. That's what the procedure looks like. That's the endothelialization. We say 45 days they have to stay on Coumadin because we expect that they're endothelialized over the top of the device. And so then we do a TE at 45 days, and as long as there's no leak more than 5 millimeters around the device, then we can stop the Coumadin. So I'm going to go into that. We kind of talked about that. So this is the slide, the golden slide. So 45 days, they take warfarin and they take aspirin, 81 milligrams. Okay. So if they have a seal, which so far everybody I've seen, knock on wood, has had a seal at 45 days, then we stop the Coumadin, we increase the aspirin to 325, and we start them on Plavix 75 milligrams a day. And then I see them back at 6 months, and if at 6 months they're doing fine, meaning, we basically have to do this for the registry. Eventually, I'm hoping they'll drop this and let us, not have to send all this in. But all this information has to go to registry, which is why they have them come back to structural clinic. But at the 6 month period, we can drop the Plavix and just continue 325 aspirin. Now, Dr. Matos sent me a message one time and said, why can't my patient just be on 81? Why do they have to be on 325? It's just because of the way the study was set up. They did it for 325. But I don't see why they couldn't be on 81. I think 325 is what we use for patients who can't take anticoagulation who have AFib. If you give them 325 aspirin. So I think that's why they use that number. But nobody from the company could answer that question for me.
Jenny, do you know, have they done studies comparing directly surgical left atrial appendage ligation with Watchman?
No, and I'm wondering that. Do you know how many patients I see that have had surgical left atrial appendage
all of our
occlusions
patients
and
are
they're still on anticoagulation?
Still on anticoagulation. And
Yeah.
that is probably a fault of surgery. We're just not as aggressive with our clinical trials. I mean, from what we've seen just in experience. So I don't know. That would be interesting to see.
I agree.
What is the seal rate?
I have a patient in the hospital
are we
right now.
checking TEEs
Yeah.
on our post-surgical left atrial appendage ligation patients to see if they're sealed? And if they are at 45 days, presumably we could follow this same protocol.
Exactly.
It's the same thing.
Yeah,
So
I would think so.
I know.
I'm kind of surprised they haven't.
We need
but
to do a surgical study here.
Yeah, that would be good.
Because
Yeah.
every patient we're in their left atrium, we're surgically obliterating that appendage. So either overselling it or sometimes I'll put a clip on it too.
Yeah.
Just a thought.
I think that's a good thought. I thought the same thing because I come across a lot of patients that have had a left atrial appendage and I'm like, why do we have them on anticoagulant? And then
And they're
everybody's
not
just kind of like,
they're not even in AFib. I mean, it's like
Yeah.
a paroxysmal AFib situation,
and they're like, oh, I don't know.
and
So, all right, 45 days to 6 months. If they have no seal, which I hope to God we don't see that, but if they have no seal, then they have to continue Plavix, Coumadin. So I tell the patients, worst case scenario, they may have to continue their Coumadin, and they've gone through this procedure for no good reason. You know what I mean? It stinks. But sometimes we'll repeat that TE at 6 months, and it will seal off more. It'll endothelialize more. So then at that point, we can go back to the basically just do 325 of aspirin at the 6 month. If the TE shows adequate seal, we don't have to go through the whole Plavix because they're at the 6 month period after the procedure. So that.